Welcome, Dr. Anthony. How are you?
Thank you, Rain. Doing well. How about yourself?
I'm doing great. Hey, everybody who is signing on. We are live for another edition of the Carcinoid Cancer Foundation's Facebook Live series. Specifically, we've been doing these weekly now during this COVID-19 pandemic, because we know that there's a lot of questions for all of us, really, but especially with NET patients about how do we navigate this? Is there special information that we need to abide by? Are we immunocompromised, et cetera, et cetera? So lately we've been doing a weekly series speaking to you all specifically about COVID-19. And we also answer general questions as they come in. But today our main topic is COVID-19 and as how it applies to your health and safety as a NET patient. So please send in your questions about that. We're super excited about this because this essentially gives us a one-on-one session with a leading doctor or specialist, which is something that a lot of us, as patients, as caregivers, didn't have access to. So we love these tools that technology, modern technology, has given us to have a widespread reach. So if you're just signing on, and Dr. Anthony, the numbers are shooting up already, so that's great. You're a big star. We just want to ask everybody where you're from. Let us know where you are in the world, where you're signing on from. We really enjoy to see the reach of this and the impact that we can have. So big thank you to Lexington Pharmaceuticals. They made this COVID-19 weekly Facebook Live series possible, so thank them for their support. And today our guest is Dr. Lowell Anthony. I had the pleasure of working with Dr. Anthony back in the fall, and just you all will see how much this man knows his information, but what I like so much about it is how he delivers it. There's a big difference in knowing it and being able to convey it. So I think we're in for a real treat today. Dr. Anthony, could you, for those few people out there that haven't heard of you or aren't familiar with you, could you tell us a little bit about yourself, specifically, where you work and how you got into this world of neuroendocrine tumors?
I am presently at the Markey Cancer Center at the University of Kentucky in Lexington, Kentucky. My interest in neuroendocrine tumor goes back to my training years at Vanderbilt. I was assigned a topic to report to the group on part of my education. And I recall in about 1982, coming across the term apodoma, and that stands for amine precursor uptake and decarboxylation. And I was intrigued because I was given the task of understanding neuroendocrine tumors that started in the pancreas and the unusual syndromes that they presented with. I never thought in 1982, when I began my fellowship training in medical oncology, that I would end up making apodomas a career. You never would think a rare disease could do that to someone. So the neuroendocrine tumors chose me. I chose early on with this interest. But then later on, because of turning a rare disease into a major focus in an academic career, it literally chose me. And that is because we had more to offer, and therefore more subspecialization was needed. So I've been doing this obviously now for 30 plus years. My experience ranges from my days at Vanderbilt to the 15 years I spent at LSU with Gene Woltering's group. And I've been here at the University of Kentucky for the last 8 years. So with that as a background, Rain, I'm happy to take on people's questions.
Right on, and we're happy to have you. Thank you so much for making the time for us today and our audience. So I see our numbers are continuing to climb. If you're just joining us, welcome to today's. This is going to be, I think, the last that we're doing specifically about COVID-19, but that's what our questions are about today. And if we have time, we can take some general questions, general NET questions as well, but we're going to try to stick to the primary topic as much as we can, because now everything is starting to change. Some restrictions are being lifted, and so the information that we needed as NET patients and caregivers a month and a half ago is different now. So we're going to try to serve you best in that way. We may not have time to get to all the questions. We can't answer very case-specific questions. So if we don't get to your questions, or you have more information that you need, I urge you to reach out to the Carcinoid Cancer Foundation, either here on their Facebook page, or you can visit their website at carcinoid.org, and they can direct you to either a specialist or where you can find that information. And also this video will live here on the Facebook page. So don't feel like you have to get everything down in this hour. We want you to join us live, but just know that you can always refer back to it. Finally, before we get started, a disclaimer from our sponsors. We just want to say that the opinions expressed by the guest presenters, which is Dr. Anthony in this case, as well as the questions asked by the audience, that's you all at home, they haven't been created or suggested by the sponsors of the Facebook Live, and CCF does not endorse or promote any of the views, opinions, or information in this presentation. Audience members should not rely on the opinions or information expressed by the guest presenter and should seek guidance and direction from their own medical advisors regarding any choices they make about their health and treatments. Okay, that was a lot of words. All it really means is we're going to do our best to give you some general advice and direction so that you can try to navigate the issue you're trying to overcome. But by all means, talk to your healthcare providers and your team to discuss the best treatments for your specific case. Dr. Anthony, would you agree with that?
Absolutely. Everyone's situation is a little different, changes over time, and I think those recommendations need to reflect that.
So I have another announcement right before we get started. This is something new to the Facebook Live offering that Facebook has. Often as we do these, if you've been joining us every week, I'll periodically stop and say, hey guys, if you're getting good value out of this, just give us a little like or a heart emoji down there at the bottom. Some of you are already using them, I see. We love that, so we know that we're helping out. Well, now there is what's called Facebook Stars, and that is something specifically for live programs like this, that each star that we are given, which is an option that you have down there, Facebook donates 1 cent, I think, to the foundation. And so you may have to start an account with them and deposit some money and have some money. But that's another way that you can show support. If we are really helping you, it's just a little thank you that's being offered by Facebook Live now, and that's something very new. So we're excited to explore that option as well. Okay. We've got 130 people joining us live so far, and the numbers are growing. Dr. Anthony, let's get into it. First, as I already alluded to, things are changing now. Certain states are lifting their restrictions, and we're not completely in this lockdown that most of us have been in for the past month or two. So my first question is, what would you say, Dr. Anthony, to a NET patient about how they should proceed right now, depending, of course, on how the restrictions that their area has, but most people are still unsure of, well, how does this pertain to me? I'm not just general public, right? I'm dealing with this disease.
So, Rain, there's been a lot of apprehension as it relates to patients going into medical centers and clinics, hospitals, etc. This apprehension should now be put into context. We know a little bit more about how to prepare for patients. We know about social distancing. We know about hand hygiene. We know about wearing masks. We know it's all about safety of the patient, safety of the hospital personnel. So as now we're 2 months into this, we can now start to have some sense of more of normalcy. And from caring for neuroendocrine patients, what we really want them to feel is symptom control. And if there's been delay in getting depot injections of somatostatin, delay in getting any procedures or medications, now's the time to start thinking about getting back in the normal, what had been done prior to the lockdown. So at our center, we are scheduling more of the elective scans and procedures, even though we never really shut down. We just slowed down. So I can't think of a single patient in my practice that did not receive the necessary care that they needed. If there's anything positive about neuroendocrine patients, is generally a few months like this does not translate into any meaningful harm done outside of the acute bowel obstruction or infection, things that we would have to deal with a lockdown or not a lockdown. So we can say that our scans are probably the greatest affected. We had to select which scans we wanted to do in the next week or two and which scans could be put off. So I did see delay in the surveillance of our neuroendocrine tumor patients. And it'll take time for us to see what impact that has, but I'm not expecting a huge impact range. So I'm going to encourage people, contact your provider, get back on schedule, get your scans ordered, get your clinic appointments made. And the other part of dealing with this is telehealth. There will be some silver linings that come out of COVID. And one of the things that impacted reimbursement, CMS and Medicare and reimbursement avenues, is it expedited the reimbursement for telehealth. So if for any reason one of our patients or not necessarily have to come on campus, telehealth now provides an option that before COVID, I didn't see happening probably for years. So this really accelerated these visits that we now can not only use Zoom or WebEx or Skype, but we can actually call and phone and get the same reimbursement that we would if we did a video conferencing. Some of the restrictions that do occur is state lines, crossing state lines. So we're going to have to deal with that. I don't see that being relaxed anytime soon.
Right. So
when I call one of my patients from out of state, there's not going to be a charge with that just based on the way our system is structured. So with that as a background of where we are today, we're starting to see more visits. We're getting ramped up 5 to 10% each week. And I would say by the 1st of June, our numbers and our volumes will be pretty much back up to what they were pre-COVID.
That's good. I mean, that's a reason for people to be hopeful, because I know so many people have had questions and there haven't been a lot of answers. And so everybody still kind of feels like they're in the dark. So it sounds like there's a light at the end of the tunnel. That's great to hear. Well, we've already had questions coming in, so I'm going to go ahead and jump to those. The first one that we had today regarding COVID-19 comes from Kathy, and Kathy says, I had a carcinoid tumor in my lung. Due to the location, it could not be resected. Instead, they had to remove the upper lobe of the lung. I haven't had carcinoids anywhere else or since, but my chromogranin A levels fluctuate between 460 and 860. And due to my levels and partial loss of lung, am I at high risk for complications of COVID-19? So I guess that's assuming that they got the virus.
So Kathy, I think what we're looking at, someone like yourself, the chromogranin can be falsely elevated. And we know that with PPIs, the proton pump inhibitors, that they will cause elevation. It'd be good to know more about if there's any disease left behind that could be accounting for this elevated chromogranin A. A gallium-68 dotatate scan would address that issue. But I would be thinking that the fact that you had definitive lung surgery, you may be cured. That's the only cure for neuroendocrine tumors is surgery. So with that context, what risk are you in having complications, having a surgically altered lung? And that's probably the context or the focus of your question, not carcinoid syndrome, metastatic disease. So we think about COVID-19 as in the cancer patient as being worse when there's immunosuppression. I don't think just having surgery is going to put you in that group of chronic immunosuppression. But be that as it may, I think social distancing, good hygiene, minimizing face touches, I think those things would apply to you just as much as anyone, but I don't think that your overall outcome will be any different having had this surgery. So you're in the same group everybody else is in.
Good to hear. Okay. Excuse me. Next question comes from Madeline. I hope it's Madeline. I saw you last week. So I hope I'm pronouncing that right. If not, I'm assuming it's Madeline. she asks, are there currently any viable alternatives to going in monthly for octreotide injections, i.e. something the patient can do at home? The COVID-19 pandemic has kept some carcinoid patients, such as myself, from any treatment other than rescue shots for the last 2 months. Because of the distance I must travel, over 300 miles round trip, and the fact that my treating clinic is in a hot spot and at least one nurse has tested positive. I live in a small town and an injection by a home health nurse is not an option.
Very good. Madeline, there are options. You could be converted to daily sub-Q injections. And that might solve your immediate problem of where you go on octreotide. There is no daily sub-Q injection for lanreotide. So it's not only control of symptoms, which you could also do with other forms of therapy if there's chronic diarrhea or carcinoid-induced diarrhea, looking at Zermelo or Telotrestat to bring the serotonin levels down would be one option. Using other over-the-counter forms for diarrhea control. Flushing, though, is mostly going to be octreotide acetate, and survival that we've known to date would be octreotide acetate. So I would suggest that you look at your daily dose of what you're receiving now. If you take your monthly dose and divide it by 30, and that probably will end up being about 1 milligram or so a day, and that would translate to be about 300 micrograms of the sub-Q drug 3 times a day. And I think that I'm trying to be as definitive as I can. I'm not giving excuses. I'm not telling you go do this, go do that, go tell your hospital to get rid of the COVID and bring you in when you need it. But what you can do yourself is have them put you on the daily form, and therefore you take the injections. I would encourage every 8 hours. Don't do the 12 hours. Some practitioners don't want to inconvenience the patient with a harder compliance regimen of every 8, but we know the drug only lasts for 6 hours. Mm-hmm. So taking it every 8 provides better coverage. There will be a pen that will be coming out in June called Benfesia. Benfesia will already be like insulin pens. It'll already be there. You just dial the dose on the end of the pen, and this would be another way that you could adapt to it, not have to draw up drug from an ampule. So if you can wait till the 1st of June or soon thereafter, you can ask your provider for that new formulation that was approved in January.
Wow, that's great news. All right. I hope that helps, Madeline. Next up, Dr. Anthony, we have a question from Helen. Helen asks, have any NET patients succeeded in receiving Sandostatin LAR shots at home given by a skilled nurse? What do you know about these programs? I think she was struggling with that.
Well, those programs are very much dependent on your insurance coverage. If it's any government involved, it can't participate, but private care insurers do, and we provide that services to a number of our patients. When we do address chronic monthly administration, first thing we want to answer is what's best for the patient. These home health agencies can meet the patient where they are in the workforce, at home, wherever they feel most comfortable for it. So that's a really good option. We've had family members who are nurses that will give their loved ones the injections. So there's a whole range of things, but unfortunately, intramuscular injections can't be self-administered.
Yeah, that was her problem. That was what she was struggling with, I believe. Okay, thanks. Moving forward, we have a question from Marcia. Marcia says, does immunotherapy offer any protection against COVID-19? And Dr. Anthony, let's establish for those who aren't familiar what immunotherapy, what that means, what that is.
Marcia, immunotherapy that we use to treat right now a whole host of malignancies ranging from lung cancer to melanoma to kidney cancer, bladder cancer, now breast cancer, hepatocellular cancer. So you can see it's gaining ground. Immunotherapy works from fighting from within. That's what I want you to really remember. This is stimulating your own immune system to identify what's foreign and taking it out. So we look at immunotherapy as being immunostimulatory, not immunosuppressant.
I like it. That helps. Let's see.
There's really not going to be enough data for us to comment because these immunostimulatory drugs have not caught on in the indolent neuroendocrine tumors. We use them now more often in small cell in neuroendocrine carcinomas, but not the neuroendocrine tumors. So we really don't have this problem for neuroendocrine tumors as such, because if you're on these drugs, you're probably part of some research protocol.
Got it. Got it. All right. Thanks. Everyone who's attending, welcome. We're about 1/3 of the way through today with Dr. Anthony. I see our numbers are doing well, and we're excited about that. So if you are just signing on, or if you signed on a little late, let us know where you are in the world, where you're signing on from. If you've been getting some value so far, send us a thumbs up or a heart, and let us know that we're doing a good job. And just a reminder, if we don't get to your question, you can follow up with Carcinoid Cancer Foundation here on the Facebook page. You can send them a message. You can visit their website at carcinoid.org. We keep this video here on the Facebook page. We also have a lot of video content on their YouTube channel that you can visit. So the information is out there if we aren't able to get to it today, but we really appreciate you all joining us. If you know anybody else that would benefit from this while it's happening right now, just hit that share button and let them know that they can join live right now. So thanks for attending, and we're appreciative of Dr. Anthony and his time. And clearly he is a highly sought after individual, because we've got quite a good crowd here today to hear from him. Okay, moving forward, we have a question from Christy. Christy asked, is it safe for a NET patient to go back into society now that things are opening back up? We kind of touched on this already, but specifically Christy is, she's worried she needs to go to the grocery store and do these normal errands. And she's wondering if she's at higher risk if she goes to the grocery store.
So Christy, I want you to stay safe. That's the critical component here. You've got to move around in an environment as you personally feel safe. If I look at you as generically as I can, and when I say that, your white blood cell count should be normal. Unless you're on Cape-Tim, and even people who are receiving capecitabine or Xeloda, temozolomide, or Temodar for pancreatic neuroendocrine, usually even in that setting, the white blood cell count remains reasonable. So as a general statement, if you're on somatostatin analogs, you're not immunosuppressed. Now, the question comes up if you're on everolimus or Afinitor. Now, this is a drug that can affect the white blood cell count. You may have some information what your white blood cell count is if you're on that drug to know whether your bone marrow has been stressed, but most people do not. But we look at Afinitor as one of those drugs that has the potential of causing some degree of immunosuppression. But generally, as by itself, it's not enough. Usually steroids or some other immunosuppressants needed for it to really act as a true immunosuppressant. So with that said, I would encourage you to start assuming a more normal life in the context of your community. Community would be, are the COVID cases starting to go down? Where you go will most likely really emphasize distances between patients. I think going out masked and washing your hands after you touch something. That's what I see our infectious disease doctors doing, keeping hand sanitizer around their neck is something that we here in the hospital will do. And I'll just bring mine out right here. Sure. This is a key thing that becomes as important as anything you can do, is to wipe down surfaces potentially, and those grocery carts and things may already be wiped down for you. I see that happening quite often. But I think it's going slow and doing things that you feel comfortable with, and doing the good hygiene and the safe distancing and things that we've all been instructed to do.
Great. Good to know. So next question comes from Dana, who is an RN. and a very good one at that too, and a friend of mine. So hey, Dana, and love to your family. Dana says, I just went back to work as an RN in the hospital. Are there any extra precautionary measures that you can suggest or advise to be extra safe as a net patient also? So now she's back in the hospital as a nurse, but also a net patient. So there's a lot going on there, I'm sure.
So Dana, as you know, there's a lot of places in the hospital to work, ranging from doing procedures, airway procedures, potentially ICU and things. So I think I would follow the guidance from your hospital as it relates to the risk for transmission. If you're in a general low transmission area, and we'll say a clinic, then I think social distancing and respecting the hygiene aspects of this will carry a heavy load on keeping you safe. So I'm not sure that there's anything special that you need to do other than be aware of maybe if there's a symptomatic patient that comes around, that you then may wear an N95 mask or do some things along that way. So I'd be prepared for the moment based on what the risk is for you, based on what your supervisor and other people around you know.
Great. Thank you. Hope that helps, Dana. Good luck to you out there, and we appreciate you fighting the good fight. And I just want to take a moment also to say how appreciative I am, and I think we all should be for our healthcare providers right now, doctors like Dr. Anthony, nurses like my friend Dana, and everybody out there who's having to deal with, I think, a lot more than they signed up for right now. And so I just want to say from me and hopefully everyone else, we appreciate you. Okay, next up, Dr. Anthony, we have a question from Gretchen. Gretchen asks, how long after direct chemo liver embolization will one be immunosuppressed?
Gretchen, how embolizations are done, it's very dependent upon the institution, as there's not one preferred procedure that's been adopted by interventional radiologists. So if you're at Memorial Sloan Kettering in New York, you'll have a bland embolization. But if you're at the University of Pennsylvania in Philadelphia, you're likely to get a chemo embolization. There's actually a study going on right now to help us scientifically determine what's better. So if you've had a bland embolization, and what I mean by that is you've not had any chemotherapy drugs delivered to within your liver, you really are not going to get immunosuppressed. What we worry more about in embolizations is the risk for abscess. Whenever there's a foreign body that's been introduced into the body, and there's tissue that becomes avascular, such as the tumor, that's the reason that they do the procedure, then bacteria possibly could form in that abscess cavity. And at our institution, we keep people on antibiotics for about a week afterwards. So abscess is what we're really concerned about. And I don't think your white blood cell count will really get that low. Even if you did get a chemoembolization, most of those cases don't result in significant myelosuppression for a prolonged period of time. But those would be the questions that I would be asking. There is another form of radioembolization. We don't do those quite as often as we used to, because we're finding that bland embolization combined with other ways that we can go about controlling disease in the liver for many, many months and now into the years. Yes. I
think for Gretchen's case, she did have chemo embolization. Any thoughts on that, and how long she may be immunosuppressed?
So chemoembolization, some of the chemo will leak out into the bloodstream, and there will be potentially some lowering of white blood cells. I would be thinking that after about 2 weeks, your blood count should be starting to come back, and certainly within 3 weeks, they should be coming back. So we normally think of chemotherapy lowering blood count starting around the 7th to 10th day, based on which drug you got and how much you received, and then having pretty much fully recovered by somewhere between the 14th day to the 21st day.
Okay, great. That's helpful. Thank you. Okay, so Christine asks, And this is actually a question I've seen multiple times over the past month and a half we've been doing this. Can you address COVID-19 precautions for dip neck patients? And let's establish for those unaware or unfamiliar with what's dip neck.
So DIPNISH is the diffuse intrapulmonary neuroendocrine cell hyperplasia. So there's actually a website named DIPNISH, I think it's .org. You can go there, and the gentleman that created it reached out for information because he had it, and he put it all on that one website. So DIPNISH is something that we've come to greatly appreciate what it is over the years. It is a chronic underlying pulmonary disease, so it would make COVID-19 more difficult, I think, in recovering, just being classified as having underlying chronic illness. You could add diabetes, hypertension, atherosclerotic cardiovascular disease, and these other diseases to it. But DIPNISH, because of the effect on the airways, the clearance, the hypersensitivity, would make, I think, a COVID-19 illness particularly more difficult to get over, particularly during that pulmonary phase. So how to keep from having it is to prevent it. So good hygiene. I'd stay off airplanes, stay out of churches, keep your distance. That's what I would really tell you to do. I wouldn't assume other people would do that to you. May not respect what chronic illness you have and may not know. But it's 6 feet, not only left and right, but it's front and back too. And staying in rooms that have good ventilation, that might be hard for you to know right off. But eating in restaurants, you might want to eat outside. But the more bodies that are within a closed space and the ventilation may not be optimal, that's the area that we're finding that these viral particles can hang around longer.
Yeah, I hadn't thought about that, about being in a well ventilated room. That's definitely a factor that could play into it.
Absolutely.
And the front to back, because that's something I've noticed just being out in public is people do think about it laterally, but like if you're standing in line, now you see, at most stores they have the little stickers on the bottom, but so many people that 6 feet will cramp up pretty quickly, and it's just like it's a little uncomfortable now.
So what I've found is if you go early or late, or if you go, you can kind of pick when the crowds are going to be low. And I've gone into Costco in the last hour before they close. There's almost no one there.
Yep,
There's more employees than patrons.
Yeah,
I'm just sort of thinking this is really great.
Yeah, I went one time at like 11 a.m. and I turned around. I just left because the line was around the store on the outside just to get in. And the next time I went was just like you said, an hour before they closed, and it was a breeze. So I co-signed that advice.
So Christina, that's the real treat right there, is find out where those low points are and don't assume anybody is going to respect your boundaries. Mm-hmm. But if they're not around there to start with, you don't have to worry about them.
Absolutely. All right. Thank you so much. So next up, we have a question. G asks, my last scans came back with further shrinkage and my counts are good. Recommendations have been to push out my scan 4 to 6 months. Would it be safe to push it to 6 months? And what would be the risks on the other hand?
So, G, when we scan people, we put it into context of what the biology is. That biology can range from a well-differentiated grade 2 and a grade 1. There is the grade 3 that we do see. If more likely, you're probably a grade 2, and those scans are usually done every 3 to 6 months. And if there's shrinkage, you could probably push it out a little bit. But it's really all dependent upon what that grade is, what treatment you're on, and what's expected to happen in the next 6 months. And if there's any anticipation that something is not as what you would expect it to be, you might want to get scanned a little bit earlier. But it sounds like, from what you presented to me, and it's probably biased because you're telling me about it, you could go 6 months. But I certainly do scan a lot of patients on a 6 month basis. So
great.
That's really good to hear, G, that you have had a response, and we're excited for you.
Absolutely. Next question, Patricia asks, can you give us an update of pills instead of Sandostatin LAR injections?
So the problem with pills replacing Sandostatin is that the development of an oral form of a peptide is in its early phases. If you could look at an oral form of insulin, we would have been there years ago. So there's several ways I can interpret this question, Patricia. One would be that you'd want to stay on the somatostatin analogs. The drugs that are being developed will not deliver the blood levels like the injections will. So they're being looked at to look at maybe rescue products, maybe for acromegaly or such. The levels are low unless there's data that haven't been shared with me recently. Oral drugs, then, if we look at for symptom control, would be Zermelo or Telotrestat. That would be for carcinoid-induced diarrhea. That doesn't replace the somatostatin in a proven way for tumor control, but we certainly do see symptom control from diarrhea. And we do know that people do better quality of life-wise if they have their diarrhea reduced, as well as their serotonin. Rain, let me just point out that when we do use a drug like Telotrestat or Zermelo, we're actually decreasing serotonin, which is one of the key mediators in carcinoid that can cause carcinoid heart disease and fibrosis throughout the body. So this is a distinction with other oral medications that are used in this disease, such as the anticholinergics, and that's the fancy word for Imodium and Lomotil, drugs that just simply slow the gut down and decrease the fluid secretion by the gut. So people who have elevated serotonin levels and diarrhea may very well benefit from Zermelo.
Great. Thank you for that. Dr. Anthony, we've gotten quite a few general net questions in, and I'd like to get to some of those. Would that be okay with you?
Yeah, it'd be great.
All right, great. So we'll go ahead and pivot to there. And if you do have COVID-19 questions, everyone, please continue to send those in because that is our priority for today. So we'll get back to those. But I just want to go ahead and get to some of these general questions because we've got a good number of them. So first up, Dr. Anthony, we have a question from Anna. And Anna says, can a person have another cancer and carcinoid too? I have tumors in my saliva glands and in my thyroid, but they do not show up on my Octria scan. What's up with that?
So when we think about people with neuroendocrine tumors, we can look at them as either being sporadic, that is, that they're not a hereditary form, or they're familial. So there can be other tumors in the neuroendocrine tumor patient, and the first thing we think about would be the multiple endocrine neoplasia syndromes. And specifically in the thyroid, this would be medullary thyroid cancer. Medullary thyroid disease frequently does not show up on somatostatin imaging. So I'd have to know a little bit more about things, Anna, to really get into your case in more detail. But the first thing would be, is there a hereditary component? And that would be MEN2, where neuroendocrine tumors usually maybe pancreas or such, or adrenal. These ones that are a little bit different from MEN1 may correlate, exist with thyroid, medullary carcinoma of the thyroid. So what we do on the sporadic side, those tumors that are not associated with hereditary, is we will screen people during scanning if there's any kidney or bladder or female organs or other sites that might be involved that might look a little atypical for neuroendocrine tumor patients. But in general, our patients don't have an increased risk for other malignancies over and above what they would be at risk for colon cancer, whatever other tumors that they would be, even without the neuroendocrine tumor.
Can Octria scans or gallium-68 PET CT scans see other tumors in addition to neuroendocrine tumors?
Excellent question. Lymphomas and melanomas are ones that could be seen with the somatostatin receptor imaging, simply because those cells in the lymphoma, it's the lymphocytes that express the somatostatin subtype 2 receptor. And in melanoma, these tumors arise from the neuroectodermal plate in the embryo, and those cells can express the somatostatin receptor. We can see high-grade neuroendocrine carcinomas express the somatostatin receptor. So potentially, almost any of them could. Breast cancer could as well, and there's been studies using octreotide to treat breast cancer. We're actually working along the lines of looking at the tissue for the somatostatin receptor, so we don't have to scan everybody to potentially consider them for somatostatin-based treatments.
Got it. Sandra asks, or she says, hello, Dr. Anthony. Are you aware or have you initiated any studies using apotone vitamin therapy to treat NETs? And if so, what are your thoughts on the success of this treatment for patients? Thank you. So first of all, what are apotone vitamin therapy, or what is apotone vitamin therapy?
Well, Sandra, my focus is not on complementary medicine or alternative medicine. My general comment to patients when they start asking me about CBD oil and vitamins is to say that if these alternative medicines work, they'd be called medicine. So we don't really focus our attention on developing alternative medicine simply because the industry supporting that doesn't have any funding to come into institutions like ours to promote the science. So most of the vitamin experimentation is done through promotional events that you may see someone touting anecdotal data. Oh, I knew somebody, and we had 6 people. They don't tell you about the 94 people out of 100 that absolutely had no benefit, but they emphasize the group that really, really did well. And so what I usually do in assessing this is look at the data to date. I'm open-minded. I want the treatment for this to be as simple as it can be. But at the same time, I don't want to give people false hope and do vitamin research where there's no real funding in it. The first thing I ask people to do if they see someone who promotes this is to say, well, if you all believe in it, why don't you just give it to me? Don't charge me for it, and then I'll tell you whether it worked for me or not. The minute they don't want to charge you for it, that's the suspect, because our patients are prey on this community of people who want to fleece them. What's your credit card number? How fast can you get money to us? They really don't care about you as individuals because they're not collecting data on you. They're just simply wanting your testimony and your money. And then if it's really working, I can tell you, I would love for it to work. And if the vitamin industry wants to come in and lay a grant on us, we're happy to support it. Happy to support it.
Got it. Okay, we have a question from Marianne. Marianne, I feel like I think I've seen you before, so welcome back if that's you. Marianne asks, I've had 4 Lutathera treatments recently, which is PRRT, correct?
Correct.
I am interested to know the options available to treat neuroendocrine cancer stage 4, level 2 to 3.
So I'm not sure what that level 2 or 3 means.
Nor am I. So Marianne, if you could maybe give us a little more information, but it sounds like she's had 4 Lutathera treatments recently. And maybe she's looking for, maybe she's looking for more options or other options.
Oh, excellent. Okay. Marianne, this is a area that more and more people are going to be facing as Lutathera or peptide receptor radiotherapy or PRRT is being utilized. And it's such an important question that for other people who haven't had it, it's good to know what might come next. So I encourage patients to ask their providers, what do you have to offer after PRRT? Are there clinical trials available? And those are some of the areas that we're focused on in developing here at the Markey Cancer Center. So in general, what's been done is that if someone has benefited from the 4 doses, it's possible that 2 half doses could provide some additional benefit. Now, is that proven? It's not proven in the sense that it's on label, but the work that's been done in Germany certainly supported the efficacy. But I'm not going to say that that is what you need. It may be that it be dependent on what your blood counts are doing, what your kidney and liver function are doing, and what could be next. But what we do know is that people who have gone through PRRT or Lutathera treatments, some chronic form of treatment needs to be sustained rather than just go off all treatment. And that can be a whole host of different kinds of drugs or treatments. And I'll have to leave that up to your individual situation of what that might be.
Got it. Next, we have a question from John who says, if a MEN1 or MEN1 patient has micronet tumors on their pancreas that are being watched but not targeted for surgery, do you recommend any tumor growth suppressor drugs be considered?
So, John, I think this is an area that specialists are really attempting to address, because no one wants to operate on you just to operate. It may take a total pancreatectomy. These MEN1 tumors, as you described them as being multiple, are usually small, multiple, and we try not to operate on MEN1 patients as a general statement, because you would go into brittle diabetes should a total pancreatectomy be required. You don't want to go in and take out part of the nodules and then leave nodules behind. So I would concur that watchful waiting is most likely in your best interest, and work along the side of a center that's very knowledgeable in MEN1, knowing when and when not to intervene in a very complex setting. Thank you for that question, John.
Yeah, John also says, are there any diet recommendations known to impact their growth one way or another?
Rain, this is a good question because we get this one a lot. John, a lot of people have the belief that these tumors feed off of sugar. Well, in the neuroendocrine tumor, we'll differentiate grade 1 and grade 2. When we do a sugar scan, I'm going to call it an FDG glucose, but that's a scan we commonly do for lung cancer, colon, breast cancer. We don't see sugar being metabolized in neuroendocrine tumors. So our advice as it relates to diet is to eat a healthy, balanced diet. And don't think that a keto diet is going to make you live any longer, because these tumors are not going to respond to a keto diet, in my opinion. Your brain and your heart depend on blood sugar, and your liver is going to make it. So you really can't get rid of sugar and still be alive. But what we do ask is people use it in moderation.
Great. That's great advice. Thank you for that. So everybody, we've got about 10 minutes left. I'm going to continue to try to push through, but I see that there's a lot of general net questions, which we won't be able to get to. So again, I just want to reiterate, please follow up with CCF here on the Facebook page. You can send them a message or visit their website, carcinoid.org, and they will direct you to the information or further information that you're seeking. And again, this video will live here on the Facebook page, so you can always refer back to it. We usually chop them up and also post this content on YouTube, so you can see smaller versions of the video. And there's a lot of questions that I get about topics that we've covered. So I just also want to mention that if you go to the videos tab on our Facebook page here, you can see all the other Facebook Lives. We've been doing this for almost a year now with different topics: lung nets, surgery, nutrition, So check back on those, because chances are we may have had someone on to address your question anyway. So finally, if you are still with us and getting some value out of this today, send us a thumbs up or a heart. And again, a reminder of the new feature for Facebook Live, the stars. If you go down to the comment section, there's a little smiley face for an emoji, and right beside that is a star, which is a way that you can help support Carcinoid Cancer Foundation, and Facebook drops them a penny for every star they get. So take a lot of stars to get some stuff done, but hey, we're trying to help you also. Help us help you, right? All right, Dr. Anthony, we got about 10 minutes left. Let's try to churn through some more questions. How you hanging in there?
Oh, yes.
Appreciate your time. Okay. Let's see. Do you know Donna asked, do you know the mortality rate for a carcinoid tumor on the appendix?
Donna, mortality rates for neuroendocrine tumors are related to somewhat where they start, but also how much. So if you're looking at metastatic disease that arises from the appendix to the liver, could be in other lymph nodes, could possibly go to bone. It's a little bit variable. It's usually in terms of years. If it's a true grade 1, it should be years, as any grade 1 is. The appendiceal carcinoids are typically not secretors of serotonin. So the syndrome itself is usually not present with an appendiceal carcinoid. So it is a little bit of a different beast. I've known some of my appendiceal patients have lived for many years. They do extremely well. So I think it's one in which the biology in the individual needs to be considered as such, because in any subgroup there can be some aggressiveness, and now that we know that the grade 2 and grade 3 exists, so if it was an appendiceal grade 3, I'd probably talk to you a little differently than if it was appendiceal grade 1 in terms of survival outcomes and what treatment options ought to be offered.
Got it. Well, speaking of grades, we have a question from Jerry that says, what high grade trials are you working on or are being worked on right now that you know of?
So, Jerry, high grade trials, if we look at well differentiated grade 3, one of the trials that we're attempting to answer is, should we be using capecitabine temozolomide, or should we be using treatment for small cell lung cancer? And that would be something like cisplatin or carboplatin with etoposide. So there's actually a trial that is a cooperative group trial that people are randomized between those two based on that histology. Other trials that we're looking at is looking at the molecular genetics of grade 3 disease. And Jerry, what I would encourage you to do is see if you can get molecular analysis, the next gen sequencing, and to see whether the TP53 or the RB1 gene, whether those two genes are mutated or not. TP53 is the most frequently mutated gene in cancer. And in small cell lung cancer, the most aggressive neuroendocrine tumor, that gene is essentially always mutated. So if you can go back and get next gen sequencing and knowing about the P53 or TP53, either name works, and the RB1 for retinoblastoma gene 1, it helps us because our bias is that when the P53 mutation's there, we need to use a platinum doublet, that the CAPE-TEM probably won't work. We don't know that for sure. And that's why this other trial is being promoted and attempting to be completed. So there are other trials going on in this, but I'll let that be limited to what center you're being treated at, and let you know what might be available at that particular center.
Got it. Thank you. Got about 5 or 6 more minutes, so I think we can get to a few more questions. Kathy asked, my mom had carcinoid cancer 20 years ago. And my sister was diagnosed 3 years ago. Should I get genetically tested?
Kathy, I'm not sure in terms of genetic testing. There is a program at the NIH that looks at familial tumors. So yes, I think you should have some genetic testing. It's not real clear at this point, what your chances are. We don't think of carcinoid itself as being a familial disease. I've had a husband-wife with the disease, and we've certainly seen twins. We've seen brothers and sisters with it. So I would encourage you to go to the NIH and join their familial registry and help us learn more about familial neuroendocrine tumors. I think you qualify based on that history.
Great, thank you. Another quick announcement to everybody in the audience. We also have the team, the CCF team, responding via the comments on this section with links to certain things that Dr. Anthony is referring to, whether it's drugs or places, links that, websites you need to visit or anything like that. We try to give you more information through the comments. So that's another way you can check through any questions that you've had if you've needed more information to fill out that answer, just an FYI. Okay, Teresa asked a question that I think maybe a lot of new NET patients might have. Well, she says, how long with no recurrence before you are cured? Are you cured?
So, Teresa, we know that it sounds like you've had surgery and that you may be in the cure group, and you're asking, when can I not have to worry about this anymore? So we look at it a bit in terms of the grade and nodal involvement. So if you had no lymph nodes involved, you're in a larger group of the cure. If there's lymph nodes involved, this puts you at risk for possibly up to 10 years. We have seen people relapse after 10 years, but I think most of this slow-growing tumor with lymph node positivity, I'd say 9 out of 10 people will relapse within 10 years. So everything's going to be based on what that nodal status is.
Yeah, that's helpful. Thank you. And thank you for your question. I'm going to pivot back to, because we have one more COVID-19 question I want to get through before we finish today. Candace asks, I had my left lung removed 3 years ago, and I work doing high-risk OB ultrasounds. I've been out of work for 7 weeks now. With my pre-existing condition, would it be best for me to find something else to do for work until a vaccine is found, in your opinion, Doctor?
So, Candace, I think people who've had lung surgery would be potentially at risk. We don't know exactly how that drainage works. There may be additional lung concerns that are there that we don't know about. So I think working in a lower risk group would be safer potentially for you. I think you have to sort of make that decision with yourself of how comfortable you think the environment might be. I think as we get further down the road with this, where the numbers in the community really drift into much smaller amounts, with the precautions that hospitals are putting into place, it may become less of a concern, but it really won't become a no concern until we do have that vaccination and therapeutic agents to offer. So if your anxiety is such that you've got to have those two safety nets, then I would totally decrease your risk for potential transmission of getting this virus. So, but it's very much of an assessment of what that workplace risk would be. And it's hard for me to do that at a distance.
Got it.
But thank you for that question, Candace, because we're faced with that a lot. And I think about it in our patients and our staff in terms of putting them at risk.
Right. Awesome. Well, thank you for that. And thank you, Dr. Anthony. Guys, we have reached the end of our session today. Dr. Anthony, thank you so much for your time. And everyone in the audience, thank you so much for joining us. We hope that you've gotten some value out of this today. And, Dr. Anthony's the new kid on the block. He's only been doing this for about 30 years. So, he needs a lot of support. So if he's done a good job today, let's flood him with likes and loves and the emojis and thank him so that he knows that he did a good job for you. Thank you all for joining us. We will continue our monthly series of the Facebook Live. I realized we had a lot of generic questions, general net questions we couldn't get to today. So again, I'll encourage you to follow up with the Carcinoid Cancer Foundation, but please tune in as we're going to continue doing these Facebook Lives because we've been really excited about the impact, how many people we're able to reach and how many people we're able to help because we get the messages from you all. So we really appreciate you being part of this. Let us know how we can better serve you. Thanks again to our presenting sponsor, Lexington Pharmaceuticals. This would not be possible without their support. Be healthy, be safe out there, everyone. We appreciate your time. Dr. Anthony, thank you again so much. Any final words for the audience?
I really want to thank you, Rain, and everyone else who's tuning in. We're here for you, and that's what it's all about. We want your questions answered. We want your disease managed to the very best that it can possibly be managed in 2020. So again, thank you, Rain. I know it takes a lot of effort to organize all this, and this is a true value to our community. So thank you so much.
Well, we thank you for being a part of it. Appreciate that. All right, everyone, have a great day. Be healthy, be safe.